Hey folks, Professor Finn here, and today we're going to be looking at Chapter 16 in Embalming History, Theory, and Practice by Sharon Gee-Mascarello. This will cover general age considerations. Before we get started, just a disclaimer. This video is intended to supplement a course of mortuary instruction. In this chapter, we'll be talking about sensitive issues such as infant mortality and the preservation of infant cadavers. As such, you are warned, and if you do not find this subject matter agreeable or highly offensive, strongly encourage you not to watch it. Again, this is intended for students of mortuary science to supplement a course of human preservation instruction and for interested members of the general public, but this is a very sensitive topic. There will not be certain pictures from the textbook in this presentation today because I feel that that is a bit too graphic for general distribution. However, those of you who do have the 6th edition, please be aware that there are some excellent pictures regarding techniques in the textbook. So let's go ahead and get the screen shared and talk about general age considerations. So age is one of the many factors considered during the pre-embalming analysis. Numerous intrinsic and extrinsic conditions influence the selection of embalming methods. Embalming considerations such as vessel selection, injection and drainage techniques, strength and volume of the embalming solution, and injection pressure and rate of flow are all influenced by the age of the decedent. The particular age of a decedent can also cause the embalmer to expect conditions common to a particular age category. So, infant considerations. At birth, the body water present is approximately 75% of total body weight. At 1 year of age, water weight declines to around 60%, similar to an adult. Body fat in the newborn is approximately 12% of total body weight and doubles to 25% at 6 months of age. This increases to about 30% by age 1. Infant skin is delicate and can easily distend if injected too rapidly and under high pressure. Harsh chemicals can dehydrate and wrinkle the skin. Arteries and veins are small. A variety of arterial tubes in different diameters and lengths are necessary. Small bore sizes will easily clog. A best practice is to insert a needle injector wire through the barrel to clear any debris. The wire can then remain for instrument storage, and most infants are autopsied. In addition to moisture, congenital disease processes and medications can further increase moisture and waste products in the tissues. Renal and liver failure can cause accumulation of waste products and both greatly increase the preservative demand of the body. Pre-injection for infants is not recommended as an embalming solution. The preservative content is low or non-existent. Despite assumptions, infants may require higher solution strengths instead of. At a minimum, you should be injecting at a standard 2% injection, maybe even 2.5% because of the secondary dilution of the infant being mostly water. Modify the harshness of strong formulations with supplemental fluids such as co-injections. Volume in solution injected will vary according to body size. Eye caps may be trimmed with scissors to fit beneath small eyelids. Cotton may be used in place of an eye cap. Apply a thin film of massage cream or spray to maintain eye closure and prevent tissue dehydration. The needle injector method of closure is impractical due to the unossified jaw bones. The barb will not properly embed in the soft bone. A musculature or other suture method can be used effectively. An adhesive glue applied to the lips can substitute for suturing. The lips can remain slightly parted. When this is done, massage cream should be placed on the tongue and buccal cavities inside the mouth to prevent dehydration. Only the corners of the mouth are glued. Create a relaxed mouth closure to produce a comfortable expression. Now, in regards to positioning the body generally, positioning varies considerably. The arms can be positioned at the sides of the body or the forearms and hands placed upon the abdomen. A toy or stuffed animal is often placed in the hands. The head may be turned slightly to rest on the right cheek for a relaxed or sleeping pose, or it may be placed straight ahead with no turn at all. Cotton or toweling can be placed beneath the shoulders and head to substitute for a head block. Attention is also given to the positioning of the legs. Infant-sized caskets are customarily full couch design, and the legs are visible. So let's talk about vessel selection in non-autopsied infants. All arteries should be usable. Size is the varying factor. So this is a fancy way of saying that just because they're babies doesn't mean there's anything different about their vasculature. The problem becomes everything is much smaller. So the three largest arteries, the carotid, the femoral iliacs, or the axillaries, are the ones we should be looking for. The common carotid artery is accompanied by a large vein, the internal jugular vein. Placing a support under the shoulders and lowering the head will bring vessels closer to the surface for ease in raising them. This is the same as an adult. Place a horizontal incision in one of the wrinkles of the neck. This type of incision is easily concealed after closure. So unlike an adult where we have three different types of incisions, 4 if you include the flap, realistically you want to place the incision horizontally within one of the folds that later on you can very easily hide using some super glue adhesive. Seal the incision with adhesive subcutaneous suture or the inversion suture. A lot of embalmers I know typically use super glue adhesive for sealing the incision adhesive. When drainage is insufficient, raise the left internal jugular vein. The second largest non-aortic vessels are the external iliac and femoral arteries. The external iliac is slightly larger than the femoral. The accompanying veins are relatively large and may be used for drainage. If a small drain tube is not available, these veins can be expanded by inserting a small forceps into the vessel. Use of the axillary artery may be impractical for efficient embalming of the entire body. The vessel is very small. You can find it, but it's pretty much useless. Use of the aorta, so the abdominal aorta. Use of the aorta for embalming an unautopsied infant requires the embalmer to make an external incision that resembles an autopsy incision. The abdominal aorta is a very large artery for use as an injection point. Both artery and vein are deep-seated, resting on the anterior surface of the spine. A small incision can be made just to the left of the midline in the middle of the abdomen and inferior to avoid the liver. The liver is usually large in the infant. The omentum is a large, flat, adipose tissue layer nestling on the surface of the intraperitoneal organs. The omentum must be opened and a portion of the small and large intestines resected from the spine to visualize the vessels. So the problem with using the abdominal aorta is we have to make an incision down the midline of the body. We have to cut deep enough to expose the intestines, and then we have to get the intestines out of the body in order to find the artery and vein resting on the spine. The vein can be opened and the blood passively drained into the cavities. Use of a drainage instrument placed into the vein is unnecessary. So essentially, you can just open it, inject, and then drain later, or use an autopsy aspirator. The lower portion of the body should be injected first, then the upper portion. So with infants, leg first if you're using the aorta, then the rest of the body. And the reason is simple. We want to see how the chemical is going to react so that when we go into the visible areas of the body that we figured out that maybe it's too harsh or whatever we need to do. We can always request a onesie, but once things are discolored in the face and hands, that's going to require cosmetic, and that's going to create even more of a complicating problem. During injection, the intestines can greatly expand. Release any fluids by clipping the intestines with surgical scissors. The entire body can be embalmed using this one-point method. Now on to the ascending aorta. Use of the aorta for embalming an unautopsied infant requires the embalmer to make an external incision that resembles an autopsy. The ascending aorta is also used as an injection point. Drainage can be taken from the right auricle of the heart, the small ear-like appendage of the right atrium of the heart. Clip open the auricle to allow drainage. The incision can be made down the midline of the sternum. Because the sternum is not yet ossified and remains a cartilage, a scalpel or surgical scissors can be used to make the incision. The incision must be held open with some form of retraction to allow injection of the aorta. Another type of incision, the U incision, can be used. This is basically a flap incision. The tissue is bluntly dissected to expose the sternum. The sternal cartilage is incised at the junction with the ribs and freed of its lateral attachments. The embalmer must open the pericardium and expose the heart and its great vessels. The entire body can be embalmed using this one-point injection method. So the moral of the story is, if you raise either of the aortas, you can embalm the entire body from there. But to do so requires fairly dramatic incisions. Cavity treatment. An infant trocar is selected for aspirating and injecting the cavities. Infant trocars are shorter in length and inside diameter than a standard trocar. The customary point of entry or a lower point, such as the right or left inguinal abdominal area, may be used. Cavity embalming can immediately follow arterial injection or be delayed for several hours. Injection of undiluted cavity chemical follows. The volume of cavity chemical varies with respect to the size of the infant. The entry site is then closed by the usual means, either a purse string or reverse suture or a trocar button. So, embalming solutions for infants. There are many suggested chemical combinations, strengths, and dilutions for infant arterial embalming. One false theory is that infants must always be embalmed with very mild solutions and low-index arterial fluids. Infant tissues contain a higher percentage of water compared to adults. Additionally, disease processes and drug therapies can increase tissue moisture and the accumulation of waste products. Solution strengths similar to those used for adult bodies are practical when supported by the pre-embalming analysis. So, the moral of the story is you need to be using a lot of professional judgment, use your experience, talk to your chemical reps, and use appropriate chemicals for infants when you are embalming infants. Harsh tissue reactions can be reduced by the addition of supplemental fluids such as humectants and other types of co-injection chemicals. Arterial fluids designed for infant use are available. The addition of trace amounts of dye to enhance complexion color is recommended. Volume is determined per case. The best practice is to raise and ligate all arteries prior to injection of embalming solution. The additional time necessary to raise arteries during arterial injection unnecessarily exposes the embalmer to chemical fumes. Inject the legs and arms prior to injecting the head so that solution adjustments can be made. Hypodermically treat the back, shoulders, trunk walls, buttocks, and external genitalia to ensure thorough preservation in these areas. An infant trocar or large diameter hypodermic needle is ideal. The head may be injected hypodermically from within the incision made for carotid artery incision, or from natural openings of the mouth and nostrils, or from beneath the autopsied scalp. Arms and legs may be injected from within the open trunk cavities or from external points. Internal compresses, referred to as inlays, are first saturated with chemical. Inlays can be placed in the interior of the neck, the cranium, and the trunk cavities. Inlays can also be inserted under the pectoral chest flaps over the sternum before suturing the trunk. Preservative gels can be brushed onto surfaces such as the calvarium of the skull and the anterior chest and abdominal skin flaps prior to suturing. So there's a lot of information here, but one of the important things to understand and start taking notes on is a lot of these autopsy embalming protocols are the same for adults. So if you learn it now, this is going to make things much easier when we are studying this in a future chapter. Cover compresses with plastic sheeting to prevent evaporation and release of fumes. External compresses of cotton saturated with undiluted cavity fluid or a topical preservative may be used to preserve areas as small as the ears or, in other cases, the entire body. Coat the interior of the cranial vault with preservative autopsy gel and apply absorbent and preservative powders. Add a quantity of cotton to fill the cranial cavity to absorb residual fluids and stabilize the calvarium once it is replaced. Often, infants are held during the memorial event to recreate weight in the head. Form a ball with a small amount of modeling clay, wrap tightly in cotton, and place into the cranial cavity. Now, it is important that if you are going to be using modeling clay, that you do wrap it in non-absorbent cotton. Clay can wick moisture from its surrounding area, so you want to make sure that anything that could possibly wick moisture from the tissues is well protected from those tissues. Several methods are used to secure the calvarium, such as calvarium clamps, drill and wire, and suturing. The inner surface of the reflected scalp and surface of the calvarium is likewise coated with preservative gel or mastic compound. We will talk much more in length about cranial restoration during the autopsy chapter. The scalp is drawn back to its normal position and sutured. The fontanelles are the spaces between the bones of the skull and the fetus and young infant. Bone ossification is not complete, and the sutures of the cranium are not fully formed. While the fontanelles are still present, fill the cranial cavity with cotton to create natural contour. The soft bone plates are aligned and sutured together with fine thread or dental floss and a small post-mortem needle. Apply mortuary putty to cover the fontanelles. This mastic material will hold the soft cranial plates in place and prevent leakage. The mastic will also adhere to the interior surface of the scalp and prevent slippage during suturing. Begin suturing on the right side of the cranium and end on the left. Select thin suture material and a small post-mortem needle. The inversion suture is ideal to invert the scalp tissues for a clean line of closure that may be easily concealed by hair, mortuary wax, or cosmetics. Super adhesive glue provides a leak-proof closure. A tight baseball intradermal suture may also be used for closure. So the moral of the story is you can close the scalp using any of the accepted ways of doing it. Suture, adhesive, whatever. What this comes down to is your skill level, your preference. The abdominal, thoracic, and pelvic cavity should be coated with autopsy gel or a preservative absorbent compound following aspiration and drying of the cavities. Fill the cavities with absorbent material such as cotton. Saturate the material with a preservative chemical. The sternum is properly oriented before replacing it to cover the open cavity. Webbed cotton can be applied to overlap the sternum and saturated with preservative chemical. The skin flaps are held together with gathering forceps to ensure proper alignment. Suturing begins at the pubic symphysis and is directed superiorly. A tight baseball suture provides a good closure. Now, decedent care is provided to all human beings after death, regardless of age. Fetuses should be preserved by supplemental hypodermic and surface methods. Arterial injection is likely impractical. Supplemental treatments are effective to stabilize the fetus until final disposition. Viewing the fetus or preterm infant is an individual choice. Size of the preterm infant determines the embalming method. All three methods are suitable. Take a breath. Moving on to children. First up, vessel selection. The vessels of children are larger than those of the infant, but still smaller than those of the adult. Arteries should be in ideal condition and free of arterial sclerosis. So you generally do not have sclerotic arteries in children unless there is a disease condition. The two major injection sites used in embalming the adult are also used for embalming the child, common carotid and the iliofemorals. There is no need to consider use of the abdominal aorta or the arch of the aorta in a children age group. The many disadvantages of the axillary artery and vein do not make this a good primary injection site. So while most things apply normally, you really don't want to be hunting around in the axillary area because it is too much of a problem. It's just the truth of it. Many in this age group are autopsied, so most of the embalming is done from the primary autopsy sites, right and left common carotid, right and left external and internal iliacs, and the right and left subclavians. Some embalmers prefer the femoral vessels for this age group strictly because their location permits the use of clothing that can be opened at the neck. The possibility of leakage or visibility of the carotid incision should be of little concern if properly prepared, sutured, and sealed. Something you'll hear a lot of people say is, well, I don't want to do a carotid incision because it might leak. If you know your job, you do your job well, leakage of a carotid incision isn't really an issue. I will say, however, that injecting via the femoral so you don't have to care what type of clothing are brought in for the upper torso is a major relief, especially if you don't have that clothing ahead of time. On to fluid strengths and volume. Fluid strength is determined by the condition of the body. Tissues are more delicate than adults. A medium index fluid in the 18 to 25 index range is most satisfactory. So, a mild arterial fluid in the normal range, 18 to 25. In cases of trauma and the effects of diseases such as edema and renal failure, appropriate fluid strength should be used, and if necessary, special purpose high index fluids. So if you have a complicated case, use complicated case fluids. Children require a smaller volume of fluid than adults, but a greater volume than that used for infants. So, moral of the story, as you get bigger, you need more fluid in solution. I know that comes as a shock to many of you. When contagious or infectious disease is the cause of death, the arterial solution strength should be of sufficient strength to sanitize the body without any adverse effect to the appearance of the body. A thorough aspiration of the cavities is necessary, followed by injection of the sufficient concentrated cavity fluid to reach all areas of the cavity. Reaspiration and reinjection may be necessary. Do not be afraid to reaspirate and reinject. Pressures and rates of flow. The rate of flow should be a greater concern than pressure to the embalmer, especially when embalming a child. If arterial solution is injected too quickly into the body, the tissues may distend. By the use of intermittent drainage, short-circuiting of solution is reduced and retention of solution is increased. Rapid injection with continuous drainage often has the tendency to remove moisture from a child's tissues. This could lead to wrinkling of the skin. The arms can be more relaxed than those of the adult, and the head positioned with a similar slight tilt to the right. Mouth closure may also be more relaxed than an adult. Lips may be fuller than the adult. Some drugs overstimulate the growth of facial hair. This fine hair can easily be shaved to prevent a negative impact on cosmetic application, because cosmetics can stick to fine facial hair and produce an unnatural appearance. This fine facial hair is called lanugo. It is important that the embalmer should remember that age is only one factor in the embalming analysis. Vessel selection and injection and drainage methods are always case-specific. Supplemental fluids. Supplemental chemicals can be used in embalming of all bodies. These chemicals are designed to enhance the preservative and disinfecting qualities of the preservative fluids, control moisture, add color to the tissues, and adjust pH of the tissues as well as the arterial solution. Age is not the single factor in determining the strength and volume of the preservative solution to be injected. I don't know how many times it has to be said, but you can see the number of times this textbook repeats this. Age is not the single factor to use, period. Intrinsic conditions within the body, such as weight and body build, moisture in the tissues, effects of disease, surgery or trauma, blood discolorations, and effects of long use of medications, all influence arterial solution strength and volume. Several extrinsic factors, such as the time lapse between the death and the embalming, the time lapse between embalming and the disposition, is also considered. So here we go. An ideal speed of delivery, called rate of flow, is defined as the injection of 1 gallon of solution in a period of 10 to 15 minutes. Healthy bodies can accept fluid at this rate of speed without distension. So if we were to say a normal rate of flow, 1 gallon every 10 to 15 minutes, which means at a bare minimum, the injection portion of the embalming procedure should take 30 to 45 minutes if ideal. If there is anything complicating, this is likely going to slow it down because you are not going to want to push that much fluid in that quickly to reduce the chances of distension. Sufficient pressure and rate of flow should be used to overcome the resistances within the vessels and to distribute the arterial solution without causing tissue swelling. A pressure setting of 5 to psi is sufficient to overcome most body resistances. So for pressure, you're looking at 5 to 20 psi. 5 to 20 psi with a rate of flow of 1 gallon every 10 to 15 minutes. This range is variable and dependent upon conditions specific to the embalmer and embalmer preference. Many prefer lower pressures. Others prefer higher pressures, and some inject with 140 psi as a standard pressure. Speed of delivery is just as variable. Everyone has their own ways of doing it. The first injection, while the vascular system is filling, should be slow to prevent arterial coagula from loosening and moving within the vessels. This method can also loosen coagula in the arteries, creating arterial emboli that can block smaller arterial branches. Multi-point injection and hypodermic embalming may then be necessary to effectively embalm tissues receiving insufficient preservation. By going slow, you might be saving time at the end of it. So advanced age. Life expectancy in the United States in 2020 is 75.1 years for men and 80.5 years for women. Embalmers customarily embalm greater numbers in this advanced age group. The number of persons living into their 80s and 90s is expected to double within several years. It is useful to identify common conditions associated with advanced age. So the first is arthritic conditions. Degenerative physical changes occur naturally with age, such as arthritis, muscle atrophy, and osteoporosis. These conditions may be exacerbated in patients confined to a bed or otherwise incapacitated. Muscle atrophy causes reduced skeletal muscle mass. The muscles of the extremities remain contracted and resist being straightened. Degenerative changes create numerous positioning challenges for the embalmer. It may be necessary to secure the body in position during embalming. Positioning devices such as body bridges and head blocks placed between the thighs and shoulders provide adequate support. Rolled bath towels placed under the shoulders also help to achieve temporary positioning. Unintentionally, it is possible to tear tendons and atrophied muscles while positioning cases with severe conditions. Leaving the arms and legs in original positions may be acceptable to the family. It is not recommended that tendons or skin be cut to achieve good positioning. It is not possible to unclench severely arthritic fingers without causing harm. So here is some important things. And this is a departure from previous editions of the book. The quote-unquote nuclear option used to be that with family permission you can cut tendons, break bones to get the position for the casket that they want. And now they are recommending that you do not do that because it's not likely going to get the desired effect and you're probably doing more harm than good. And when it comes to those arthritic fingers, you are not going to be able to undo those things without damaging the body. So you are best leaving them as is. When the legs are drawn to one side or in the fetal position, use of the femoral vessels is limited. The common carotid would be the best site for injection. If it becomes necessary to inject the legs, an attempt can be made to raise the femoral or iliac artery. The popliteal artery may also be a choice. If these vessels are found to be sclerotic, an attempt should be made to inject using a small arterial tube. Even if you have very bad arteries, it is always better to try to get a very, very small arterial tube in there and inject something than just go immediately to a hypovalve trocar or infant trocar in injecting and then relying on supplemental treatments. Frequently, a loss of weight is manifested in the facial tissues of the elderly. After mouth closure, place cotton or mortuary putty over the teeth or dentures to fill in sunken areas of the cheeks. With mouth closure, consider natural and acquired facial markings to avoid overfilling tissues. Atrophy of the two maxillary bones, the maxilla and mandible, may prevent use of the needle injector method of mouth closure. A method of suturing is advised for mouth closures. So in advanced old age, if you have very weak bones, probably want to go ahead and err on the side of caution and use a suture. Arteriosclerosis. Although not a problem exclusively to older age groups, sclerotic arteries are frequently encountered in advanced age. The artery most frequently affected by sclerosis is the femoral artery. The artery most frequently affected by sclerosis is the femoral artery. The common carotid artery is the best primary choice when sclerosis is present in the femoral vessels. Rarely is the carotid found to be sclerotic. Gangrene may also be present. Treat wet gangrene hypodermically with a cauterizing chemical. Apply a compress covered with a plastic sheet. Gangrene of a limb can be dressed in a plastic garment. Arteriosclerosis can also cause an aneurysm in a blood vessel. An aneurysm is an excessive bulging in the wall of a blood vessel causing the wall to weaken. Leakage of the embalming solution during arterial injection will occur at the site of a ruptured aneurysm. Classic signs that an abdominal aortic aneurysm has ruptured. Upon injection, there is little to no blood drainage, the abdomen distends abruptly, and the solution distribution is not observed. I'm going to say this again. Classic signs that an abdominal aortic aneurysm has ruptured. Upon injection, there is little to no drainage. The abdomen swells very quickly, and no distribution or little distribution is observed. At that point, you have a major blowout. A 6-point injection is necessary, followed by sectional injection. Hypodermically treat the trunk walls to ensure preservation. Senile purpura. Senile purpura or ecchymoses is an extravascular, irregularly shaped blood discoloration that often appears on the arms and the backs of the hands. The condition is brought about by fragility of the capillaries. In the elderly, excessive medications, blood-thinning drugs, vitamin deficiencies, uremia, hypertension, thin skin, and slight bruising can easily lead to senile purpura. These discolorations vary greatly in size and do not clear during arterial injection. Often, the affected area becomes engorged with fluid and swells during arterial injection. Handle areas of the hands affected by purpura with caution. Tissues easily tear. When senile purpura is present over the hands and the arms and often the base of the neck, the arterial solution should be strengthened. So, you have to ask yourself, what is going on here? Purpura is a fancy way of saying bruise. How do bruises happen? They happen when blood vessels rupture. So if you have ruptures, you need to make sure you're putting in a minimum amount of strong solution to ensure preservation without all of the swelling that is about to be happening because of those ruptures. So that is what it's saying. If you see this large area of bruising, you should probably go higher than 2%, 2.5%, 3.5%, in order to make sure that you are getting the most bang for your buck. Malignancies. Positive advances in medicine and patient care have influenced the increase in life expectancies. Longer lifespans increase the probability of malignancies due in part to exposure to numerous and varied environmental factors. Cancers or neoplasms that begin as localized tumors can easily invade healthy tissues, spread via the blood vascular system, and invade organs. This can disrupt vital functioning to the point of death. Both local and systemic effects of malignancy have an effect on embalming. Weight loss and emaciation procedures unsupported, senile skin, loose and flabby. The skin can also be dry due to the inability of the body to retain proper water balance. Cancer deaths are often attributed to pneumonia and respiratory arrest. embalming solution should be of moderate strength at above 2% and well coordinated by the addition of supplemental chemicals such as co-injection. Metabolic disturbances and renal and respiratory failure often accompany malignancy. The result is a buildup of metabolic wastes in these tissues. Waste products increase the demand for preservative. The more garbage there is, the more preservative you need because it's going to react with the body tissues as well as the tissue wastes. Cardiac disease. Cardiac disease may be treated by surgery such as heart bypass or valve repair. Incisions will be present when death occurs within days or a few weeks post-surgical. Edema in the facial tissues is common when post-surgical therapies involve large volumes of intravenous fluids. The common carotid artery in the internal jugular vein is the ideal primary injection and drainage technique in these cases. A moderate to strong arterial solution with the addition of dye helps to indicate the distribution of arterial fluid. When local obstructions exist, sectional embalming is necessary. When recent incision closures leak during injection, suture over top the existing staples or sutures or remove them altogether and apply a new closure. Remove metal staples with a hemostat. Dry the incisions and hypodermically treat discolored or inflamed tissue margins. This can be a sign of infection. Remove implantable devices such as cardiodefibrillators and pacemakers when cremation is the form of final disposition. Deep breath. Almost done. Diabetes mellitus. Diabetes mellitus is a group of diseases resulting in excess sugar in the blood. Insulin helps to regulate blood sugar level. Insulin therapy is a primary treatment for diabetes. The principal manifestations of diabetes include hyperglycemia, which is excess sugar in the blood, glycosuria, which is sugar in the urine, and ketosis, acidosis characterized by the presence of ketones in the blood and the body tissues. A strong odor of acetone may be noted due to its presence in the urine and the perspiration. Pathologic changes include poor peripheral circulation, particularly in the lower extremities, and degenerative changes in the small blood vessels. Kidney failure, enlargement of the liver due to high sugar content, and fungal infestations of the lung can also be prevalent. Skin infections lead to pruritus, a condition characterized by chronic itching of the skin. So what is happening here? As the diabetes starts really playing havoc on your body, you start having a compromised immune system. As your immune system becomes compromised, things such as fungal infections and whatnot that might not normally get a hold start taking hold, and your body has an inability to fight back against it. Restricted cervical injection is recommended. 2 different arterial solutions can be used for separate injection of the trunk and head. Largely inject something very strong into the body to treat all these issues, and then do what you need with the head to ensure a proper viewing appearance. Cavity embalming should immediately follow arterial injection and be thorough. Fungal infections can be localized in the respiratory tract. So when you are dealing with diabetes mellitus, the moral of the story is there is no waiting to do cavity injection. Do it immediately thereafter because of the fact you may have all these underlying hidden hazards in the abdomen and the thorax, and it's better to get in there and get ahead of the game. Inject liberal amounts of cavity fluid into the liver and lungs. Place plastic garments on the lower extremities when ulcerations are present. And there is a list of recommended treatments in your textbook. Another moral of the story here is when you're dealing with diabetes in the cadaver, do not be afraid to re-inject and re-aspirate. You eventually win through cavity embalming because every time you do it, it hits more and more stuff. So it is best for you to go ahead, take the extra time, spend the extra money to do that re-aspiration, re-injection, than to maybe deal with the effects of purge. Folks, this concludes the lecture. We will see you next video.